Thanks, Rahul. It's my pleasure to introduce Dr. Tobias Strunk. He is a pediatrician trained in Germany and then came over to Perth to be further trained as a neonatologist. He is a keen academic working on particularly infection, inflammation, and the underlying pathways, but also he's done quite a lot of clinical research with the main sort of intervention trying to prevent late onset sepsis infection, and we invite him to speak about that today. So Tobias, over to you.
Thanks very much. Thanks for the kind invite and introduction. My pleasure to be here, and good afternoon, everybody.
Recording in progress.
I'll just share my screen and got it, and presentation, and you should be able to see that now.
Yeah, we see it all.
Perfect. All right. Thanks again. So today we'll focus our attention on late onset sepsis and what is known, what we can do to try and prevent it. And it's not a surprise to any one of you in the audience that we face a huge microbial challenge with the transition from intrauterine life to life outside the mother. And babies are quickly colonized with a myriad of microorganisms. Lots of them commensals, and they coexist with the babies to mutual benefit, but there are clearly pathogens that are known to cause infections and really put the baby's life in danger. And in the context of preterm delivery, sometimes commensals can cause similar issues, and we'll just dive a little bit deeper into what's known and what we can do to try and prevent infections. Just to put it into context, recent data from high resource settings, early onset sepsis typically expressed as a rate per 1,000 live births, and you can see how highly dependent even the risk of early onset sepsis is on gestational age. But today we'll focus on late onset sepsis, and this graph gives you data, fairly recent data from the Australia-New Zealand Neonatal Network. And the different shades just indicate the different years, just to give you an idea of what changed on an annual basis. And then you again can appreciate the significant impact that gestational age has on the risk of acquiring late onset sepsis. But I think this graph also highlights that we haven't made a great deal of progress in reducing the rates of late onset sepsis. And it's important to note also that the burden of neonatal infection largely mirrors the burden of preterm birth. And this map displays the most recent estimates on the burden of preterm birth around the world, with increasing shades of pink indicating higher incidence. And it very clearly, these births predominantly occur in sub-Saharan Africa and Southeast Asia, where the additional challenge is that robust data collection and the quality of data often is much more difficult to obtain. And since these are estimates and very likely to underestimate the true size of the problem. Important also to take in this pyramid, where you see from the bottom up the number of births. Clearly, preterm babies, not as common as term babies, but a total of 15 million babies are born too early every year, and just about 800,000 are born extremely early. And the pyramid also indicates the health system care needed by these different patients of different maturity, and also the potential loss of human capital, whether this is neonatal death or lifelong consequences of early birth. And when we talk about neonatal death, we cannot not talk about infections. If you look at the most recent breakdown as to the causes of neonatal deaths, infections feature very highly. And in fact, if we summarize, the neonatal period carries 40% of all childhood mortality, and 75% of that occur in the first week of life. And it's estimated that around 40% of all neonatal deaths are caused by infections. And if you then combine preterm birth and infection, they are by far the most common causes of death in all children under the age of 5. So it continues to be a very substantial problem, not only in our NICU, but at a global scale. And unfortunately, the risk of infection isn't only applicable to the neonatal period. This is data from a large study that we conducted a few years ago of 700,000 deliveries with almost 9 million years of person follow-up. And the breakdown really is by gestational age brackets. The reference value here of 1 gives you the risk of a patient being readmitted to hospital as an expression of the seriousness of infection during childhood. And you can see that with every week born before 39 weeks, the risk increases. In fact, if you calculate it, there's a 12% increase in the risk of readmission to hospital for each week born before 39 weeks. And the other important feature that I'd like to draw your attention to is that this risk doesn't go away in any hurry. If you look for babies born under 30 weeks gestation, when they're in early adolescence, they're still at twice the risk for readmission to hospital compared to term babies. So it's something to keep in mind that when the baby is ready to go home from the NICU, the risk of infection, unfortunately, isn't over yet. And of course, the consequence of this realization of the risk cannot be to treat every baby with antibiotics, and especially not indefinitely. Otherwise, we will run out of antibiotic option in 20 years' time. It's already a challenge. And we have a problem with antibiotic therapy. If we look at recent data from India and Pakistan alone, 80,000 newborns die in those 2 countries from resistant organisms each year. So it is a problem, and we do need to consider how we can move forward and ideally prevent infections from happening. And before we dive into data directly relating to outcomes, it may be worthwhile just spending a moment going over the 3 principal phases of our body's defense. And it really starts with something very important that we may not always be paying enough attention to, and those are the simple anatomical and physiological barriers. And of course, the immune system, whether this is innate or adaptive immune system, cellular or humoral, they don't act in isolation. They're very much integrated, and one phase seamlessly moves into the next. So keep this schematic representation in mind as we progress through the talk. It is quite surprising that given the amount of information and the depth of information we have on the ontogeny from live as an embryo through the fetus to postnatally on many organ systems, how little we know about the immune system of the neonate still, and especially of that of the preterm infant. We do realize the risk of infection is very high around birth and then declines as the child gets older. And concurrently, the immune system matures and is able to provide more appropriate protection. We have fairly good information from 1 year onward, much less in infancy, hence the dotted line. And as we proceed to before term equivalent age, the amount of data becomes even smaller. And that's despite the risk of infection rising exponentially. So returning to this graph and speaking a little bit more about phase 1, our anatomical and physiological barriers. What happens if phase 1 fails? You really are in trouble, because once pathogens have crossed epithelia and enter macrophages, they are much closer to causing harm to the host and are much more dangerous. So thinking of what phase 1, 2, and 3 entail, what has past evidence tested actually? What parts of our defense systems have we targeted? So there were interventions targeting the innate and the adaptive immune system, so phases 2 and 3. And then we have some interventions that we haven't maybe thought about it that way, that target phase 1. That's interventions targeting the intestinal mucosa, the respiratory mucosa, and of course the skin. And we'll go through these in a bit more detail. So let's start with what we know about interventions that target the blood immune system directly. And this is some time ago now, about 20 years ago, there was emerging data with mixed evidence from the pilot trials that was inconclusive around the use of hematopoietic growth factors. And then there was a more sizable trial, the programs trial out of the UK, with 280 babies, very preterm birth, that administered granulocyte macrophage colony stimulating factor for 5 days, starting within the first 3 days of life. And this trial, as a primary outcome, had sepsis-free survival. And indeed, GM-CSF definitely works. It increases the neutrophil counts, even in babies that were born with leukopenia, but there was no resulting change in sepsis rates. It was safe, long-term outcomes were unchanged, but it was not an intervention that gained traction due to these results. Thinking more about phase 3 intervention, phase 3 of our defenses, targeting the humoral immune system, there were quite a sizable number of trials investigating the usefulness of polyclonal immunoglobulins. The latest Cochrane review on this topic was published 3 years ago now, and collected data on more than 5,000 participants. It was generally safe and well tolerated, but its prophylactic use only resulted in a very modest reduction in sepsis, and all the other outcomes assessed were just the same between recipients and those of placebo. So surprisingly for a Cochrane review, there was a very clear conclusion that there was no justification for additional trials, at least of the same preparations already studied. So if we move from polyclonal non-specific immunoglobulins into slightly more specific therapy, and that's anti-staphylococcal immunoglobulins. There were a couple of products on the market, and those underwent evaluation in clinical trials. These were derived from human donors that just happened to have high titers against staphylococcal species, predominantly against Staph epidermidis and Staph aureus. And there was also a sizable number of study participants of very or extremely low birth weight. Unfortunately, both preparations did not result in any reduction of acquired late onset sepsis and were thus not recommended for routine use. People then tried to be even more specific and designed a high affinity monoclonal antibody against Staph aureus. There were 3 studies that demonstrated safety. They were of a limited sample size, but there was simply no effect at all on staphylococcal sepsis, and no further trials were conducted subsequently. So returning again to this overview, one can wonder whether targeting the humoral immune response, which was for good reason, because we know that babies are born with fewer antibodies on board and much lower immunoglobulin levels depending on gestational age, and they are much more likely to have low neutrophil counts as well. But simply targeting phases 2 or 3 of the immune system so broadly doesn't seem to work. So maybe we're better served by targeting the anatomical and physiological barriers. So let's focus on these aspects for a moment. And our epithelial surfaces have a few things in common, that they all resist infection in 3 main ways. We have mechanical defenses, simply the integrity of the mechanical barrier. And we have chemical defense mechanism that can be pH, low pH on the skin, for example, in the stomach, in the vagina. And then we have microbiological defenses, and that's the microbiome of those different organs. And if we look at preterm skin, I think we should regard preterm skin a priori always as injured skin, especially at the limits of viability, 23, 24 weeks. If you look under the microscope, preterm infant skin has very few, if any, stratum corneum layers, and essentially the dermis is exposed. In more mature babies, still the stratum corneum is very thin, highly susceptible to irritant damage, whether this is disinfectant or tape. Easily those layers can be removed and damaged. The skin is exposed, providing access for microorganisms to the underlying structures and the bloodstream. A similar concept applies to the preterm mucosa. If you compare the term infant intestinal mucosa on the top to the preterm infant mucosa at the bottom, you can see there are significant effects afforded by the degree of prematurity. And these involve important mechanisms for first-line defenses. The mucus layer is patchy. There is increased permeability at the tight junctions, fewer Paneth cells, and reduced antimicrobial peptide levels. Now, what does this mean? It doesn't only mean that pathogens can potentially have easier access to the bloodstream. It also means that the balance that facilitates a normal intestinal flora is perturbed. And oftentimes we do further interventions like the mode of delivery, administration of antibiotics, the type and degree at which we feed and invasive devices that can cause further perturbation to the developing microbiome and the related immune responses in the gut. I've alluded to antimicrobial peptides a few times. These are a very important collective of short cationic peptides, various groups, defensins, cathelicidins, histatins, that all play a similar role and follow a fairly similar mechanism of action. They are all able to insert themselves into bacterial membranes or bacterial cell walls and form holes in them. And this is described in an electron microscopic image here with unexposed bacterial cells on the left. And then only a few minutes after exposure to antimicrobial peptides, lots of holes have been formed in the bacterial membrane. They leak and the bacteria die. And we all have antimicrobial present in all our bodily fluids and our bodily surfaces. It's part of the crucial first-line defense. But our view and understanding of what these antimicrobial peptides do is emerging. And just as an example here, I've shown you a representation of the skin, because what we're learning is that antimicrobial peptides are not only antimicrobial, they also modulate the evolving microbiome. And there really is a complex interplay between the host's antimicrobial peptides and the growth of commensals, which is typically promoted. And so they have a further strengthening of the occupation of their physiological niche and can defend it better against the pathogenic microbes that we are much more fearful of than of the commensals. But we do a lot to perturb the evolving microbiome. Some of these things we have control over. Others we are kind of given, but let's focus on those things that we have control over. We can all agree, I think, that we are experts in messing with the microbiome. Some things, we can blame the obstetricians for convenience. Gestational age, we typically don't decide. Mode of delivery, we have little say in. Broad spectrum antibiotics is a different story. Skin-to-skin contact, we have some control over. The NICU microbiome, how well we look after that, the measures we take to control it, whether we apply parenteral nutrition and how long for, enteral feeds and what we feed. So that, again, some worthwhile opportunities to delve into further. Let's focus on human milk feeding for a moment. I think we all agree it's the feed of choice, especially for our preterm babies. It's rich in immune factors. Its composition changes significantly. And I've shown you a representation here on the right during the first 25 days of lactation. One shortcoming of human milk feeding is that much of the evidence for benefit stems from cohort and observational studies. There are very few RCTs of size, and that's unlikely to change given what we already know, given what standard practice and also ethical concerns of not feeding human milk. This is an important graph from one of our PhD students who's done a great job of following the mothers of lactating preterm and term babies over the first month of lactation. And I would like to draw your attention to two distinct factors. And one is that we have the representation here of different types of milk. C is colostrum, transitional milk, and then mature milk from left to right. And then also we have, in increasing shades of gray, we have extremely very moderate preterm infants and term infants. And the takeaway message from this graph really is that colostrum always contains the highest amount of antimicrobial proteins and peptides, whichever ones we looked at, and that mothers that gave birth to preterm babies produce higher amounts than mothers who gave birth at term. That again illustrates the importance of feeding mothers on milk, ideally because of particularly high levels of immune factors early on. And probably also that it should be fed in the sequence with which it was expressed. This is a further graph from the same body of work from our PhD student who looked at the association of the volume of milk fed to babies and their risk of acquiring late onset sepsis. Again, this of course is not clinical trial, this is retrospective data, but the distinction is still very clear that babies who did not suffer from late onset sepsis were fed human milk earlier and at a greater volume than those babies who later acquired late onset sepsis. Similar data from another group, breaking down the amount into low volume human milk feeding, moderate and high, and putting it into context of the proportion of infants who've survived free of sepsis. And clearly, the more human milk babies received, the lower their risk of acquiring late onset sepsis. Now, as I mentioned, the level of RCT evidence is low. We only have about 1,000 babies in those studies. And from those trials, the evidence of protection afforded by human milk feeding is not there. We have substantially more babies in observational studies, 1,000 compared to 6,500 here. And while there is heterogeneity, collectively, the evidence from these observational studies suggests a substantially lower risk of late onset sepsis in preterm infants fed preferentially human milk. Now, it's not only about what type of milk we feed, but it could also be important when we start feeding. Now, what does the current data tell us about that question? So here, the results are represented comparing early feeding defined as starting before 72 hours. Now, one could say in 2023, commencing feeds at 72 hours could be considered late. But this was the comparison from retrospective data before or after 72 hours. And based on a relatively small number of RCTs and only 600 participants, there was no clear evidence of benefit of starting earlier rather than later. Another question is, of course, about the increment at which feeds are changed every day. And in this particular trial, the rates were either called slow, 18 mils per kilogram per day, or 30. This trial was designed to detect differences in neurodevelopmental outcomes, not particularly aiming at sepsis, but it was reported. So firstly, looking at some simple outcomes, they did achieve an earlier time to full feeds in this cohort of babies born before 32 weeks of 7 compared to 10 days, and fewer TPN days, 9 versus 11. However, in their reporting, they saw no difference in late onset sepsis rates. However, unfortunately here, there was combination of microbiologically confirmed or clinically suspected late onset sepsis, which is clearly not ideal. As for suspected sepsis, we're wrong at least half the time. I'd also like to share some institutional experience from our hospital over the last 20 years. And you can see clearly that both our day at initiation of first enteral feeds declined substantially over the years and is now probably within the first 24 to 36 hours and largely dependent on availability of expressed breast milk or consent for donor human milk. And we've also seen a substantial reduction in the time to full enteral feed. So this is the cohort of babies born less than 29 weeks, and the average time to full feeds is now 8 days. So what's helped this? This was, of course, pragmatic changes over time, not a randomized trial, but key factors that played a substantial role in this change was the introduction of a standardized feeding protocol, equally routine probiotic supplementation, availability of donor milk, and then with increase in confidence from everybody involved in feeding preterm infants, a change in culture. But feeding alone, of course, it doesn't work in isolation. Feeding faster and achieving full enteral feeds with less feed intolerance also allows us to get away from the use of central venous lines. And you can see that our use of all central lines or UVC and PICC lines in isolation has declined since 2015 quite substantially. And if you use less central lines, very likely you will have to use less antibiotics, because less commonly are we concerned about line infections. We can't not talk about probiotics in the context of late onset sepsis. So what is the evidence from randomized trials? So the most recent meta-analysis of the RCTs reporting late onset sepsis as an outcome involves 10,000 babies. There are, of course, more babies in trials with probiotics, but not all reported that. So not a huge effect size, but highly significant. We have many more babies in observational studies of routine probiotic supplementation, similar effect size. And then more recent reports from the German Neonatal Network reporting separately for very low and extremely low birth weight infants with very similar effect sizes. And equally, most recently, our New Zealand colleagues published their experience, again, very much in line with the reports published by others. But there are, of course, remaining questions around probiotics still. There's still the question about strain-specific effects and how important they are. It seems likely that multi-strain products are better than single-strain products, but which strains exactly should we combine, at which dose, and for how long? Could there be additional benefit provided by giving prebiotics as well, or combining them in a symbiotic product? Should we pursue, excuse me, just have to drink it. Do we want to pursue a puristic approach or a more pragmatic approach? And we can clearly tell around the world there are proponents for each. I think we can all agree that there needs to be broad access to standardized products, manufacturers to really stringent quality control, and that there does need to be ongoing monitoring for adverse effects, and also monitoring for the development of antibiotic resistance. Sticking for a moment with interventions targeting the intestinal tract, of course, we will need to talk about lactoferrin. The pilot RCTs and Cochrane reviews from the late 90s, early 2000s were very promising and ultimately prompted the conduct of large randomized controlled trials, both in the UK and another one led from Australia, both of which were disappointing and did not show benefit in reducing late onset sepsis. There was a meta-analysis shortly after the publication of these trials that combined all of the evidence and suggested that there might still be a benefit, although there was significant heterogeneity and risk of bias predominantly in the earlier studies. And there are questions still around lactoferrin. While it's not generally recommended for routine use at present, one could still ask, did the trials not succeed because there might be product-specific effects? Is human lactoferrin preferable over bovine lactoferrin? It may be more efficacious, at least that's what we've seen in laboratory testing. It is, however, about 10 times more expensive than bovine lactoferrin. One can also question the dose that was used, because if a human preterm baby is fed mother's own milk at 150 mils per kilogram per day, it receives already between 200 milligrams to 1 gram of lactoferrin. So providing an additional 200 milligrams in a trial, is that going to make a difference? So those could also be considered. Or should it be a subgroup of infants? Should we only supplement those not fed human milk, because not routinely human milk replacements fortified with lactoferrin? And I'd now like to change the surface and move on from the gut to the skin. I think neonatal skincare really is a missed opportunity where a lot of good can still be done. Preterm baby's skin most of the time looks beautiful in the first day or so after birth, but it changes rapidly. And as we've described previously, it is very vulnerable to all sorts of irritants and exposures. It quickly looks like this after birth. And that is intimately related to risk of acquiring sepsis with skin commensals. I mentioned before, preterm infants, or any infant skin really, is colonized rapidly after birth. And while it's not only about the skin integrity and the mechanical barrier alone, we also need to consider the chemical barrier. And preterm infants are significantly deficient in that regard too, in that they have much lower concentration of antimicrobial peptide concentrations in and on their skin. And if we could devise ways of increasing the feasible endogenous production, that may be beneficial. This is an old study, but very valuable in describing the rapid colonization of preterm infants after birth with a myriad of bacteria, but very predominantly staphylococci. More than 80% were Staph epidermidis, and then lots of other bacteria, some of which have names that we're very much fearful of. And given the predominance of staphylococci on the skin, it is not surprising to hear that they also are the most commonly isolated bacteria in late onset sepsis. But we are slowly changing our view of Staph epidermidis from seeing it as a potential pathogen more to seeing also the benefits, because it is critical to inducing commensal specific tolerance. It's critical to provide skin immune homeostasis, and in fact has been shown to result in improved wound healing. And all these effects are much preferable and beneficial compared to what we experience with Staph aureus, for example. So what do we know about the skin surface vascular catheter and late onset sepsis? Again, the evidence is largely derived from cohort and observational studies, very few RCTs. But I think we can identify a few key questions. Are central catheters, for example, more dangerous or provide a higher risk of late onset sepsis than peripheral catheters? There is some insight from Canadian Neonatal Network data that have compared infants that were provided with the PICC line on day one versus the combination of a UVC and a peripheral IV versus a peripheral IV only. And they did not observe a difference in line-associated sepsis. So it isn't quite clear. It may just be the presence of an intravascular catheter through the skin. Dwell time, of course, is an important question. Again, our Canadian colleagues have provided some insight on this and saw the greatest increase in risk after a dwell time of greater than 4 days, and parenteral nutrition provided for longer than 7 days. Reducing the rate of catheter-associated sepsis by impregnating catheters with antibiotics, for example, rifampicin, seemed like a potentially attractive intervention. The largest trial on this is from the UK, where they randomized 860 babies less than 32 weeks gestation who all required a central catheter as judged by the clinician to receiving an impregnated or a standard PICC. And if we look at the time of greatest risk of late onset sepsis around day 12 of life, you can see clearly no difference. And if we look at really long dwell times, a month or longer, in fact, the standard catheter afforded a lower risk of acquiring late onset sepsis. So we've been talking for a while now, so let's just pause for a moment and take stock. We have failed so far to identify the specific defects that underlie preterm infant susceptibility. That makes it really hard to provide specific interventions or even to provide monitoring to identify babies at highest risk. So at this point, really, what we can do is focus on fairly simple general prophylactic interventions. And what are these? Interventions with proven efficacy, really aseptic bundles that have variable combinations of aseptic interventions, such as focus on improving hand hygiene compliance, judicious use really of any indwelling plastic devices, paying a lot of attention to the NICU environment or the NICU microbiome, a variety of other infection control measures, antimicrobial stewardship. And then I think we have solid evidence on feeding, ideally mother's own milk, which probably should be unpasteurized, although I'm aware that practice varies around the world, along with introduction of a routine feeding protocol, ideally availability of donor milk, and of course, routine probiotic supplementation. And what's on the horizon? Again, I'd like to draw your attention to some simple prophylactic concepts that are currently under evaluation, although it is sobering. If you look at the big trial databases, there's a real dearth of large-scale clinical trials that evaluate any interventions that could prevent neonatal late-onset sepsis. Skin emollients are some of them. There are some investigations on oral colostrum administration, and there are still some trials investigating various aspects of lactoferrin supplementation. And I've added here early kangaroo care, and I'll show you some data on that. Speaking briefly about emollients for preterm skin care, this is clearly not new. Natural oils have been used for thousands of years in low-resource settings and had a resurgence in the early 2000s, where there were a few trials conducted largely using mineral oil derivatives. Some of the things we've all commonly encountered: Aquaphor, Eucerin, petroleum jelly, Dermavine, and so on. And then we have the group of natural oils. Probably the largest number of babies enrolled in trials is around coconut oil and sunflower oil. But important to say that currently none of these products are actually licensed for use in the NICU. If we look at mineral oil derivatives, that was disappointing. And in fact, in the babies at highest risk of late onset sepsis, under 750 grams birth weight, increased the risk. And that goes back again to the schema that I showed. Simply improving the physical barrier only may not be enough. While it wasn't measured at the time, it appears very likely that there were adverse effects of the mineral oil derivatives on the microbiome and possibly on the chemical composition of what we find on the skin too. Natural oils, there is limited evidence at this point, but it appears promising, and this observation is consistent with the observation in our own institution. And as you might be aware, we are currently conducting a large cluster randomized trial to evaluate whether coconut oil can reduce late onset sepsis in preterm infants. This trial is recruiting 1,200 babies under 28 weeks and will complete recruitment hopefully in just over a year's time. Another very simple but promising intervention, I believe, is oropharyngeal administration of colostrum, or if you'd like to make it sound more sophisticated, one could also call it oral immunotherapy. That's how it's labeled in some of the trials. It literally involves the administration of small amounts of mother's own colostrum from the time that the first feeds are initiated. Typically, volumes of around 0.2 ml are administered into the mouth, in some studies even into the nose. And collectively, we have evidence from smaller scale studies that suggest that there might be benefit on late onset sepsis. And while not strictly speaking late onset sepsis, it's still a condition that we observe in our NICU population too, is ventilator-associated pneumonia. And there may also be a benefit that warrants further investigation. Something very simple, something that fits well with our concept of family integrated care is also kangaroo care, and when we can implement that and what benefits that may have. Many of you will have heard or read this, the results of this large trial conducted in low-resource setting in Africa and India. Fairly small babies between 1 and 1.8 kilos that were randomized to receive immediate kangaroo mother care or conventional care. And the primary outcome that was targeted was death. So if we look at the study outcomes, a substantially sized study with over 3,000 participants, and amazingly, they achieved the median time to initiation of first skin-to-skin contact within 1.3 hours. And the median duration of skin-to-skin contact on a daily basis was 17 hours. Probably not something that we can achieve immediately, but certainly worthy of noting to just appreciate what is possible. If we look at the outcome, their primary outcome was death during the neonatal period, substantially reduced in the intervention group. Other important secondary outcomes, I guess this one isn't entirely surprising, but less hypothermia observed in those babies receiving early kangaroo care. And importantly, a significantly reduced incidence of sepsis too. Just about a month ago, there was a good meta-analysis of the available data on kangaroo mother care, first comparing administration of our provision of kangaroo mother care versus conventional newborn care and looking at the key outcomes. One, of course, is sepsis, substantially reduced. And then the comparison of kangaroo mother care initiated within the first 24 hours or after 24 hours. And again, it reduced the risk of death and it reduced the risk of sepsis. So certainly something to think about. I don't think we have data from the ANZNN at the moment as to when kangaroo mother care is first initiated typically and how much time babies spend, say, in the first month of life. But it would be certainly a very interesting investigation. And just to highlight from the conclusion of the latest meta-analysis here, the findings support the practice of kangaroo mother care for preterm and low birth weight infants as soon as possible after birth and for at least 8 hours a day. 8 hours or more seemed to provide a substantially greater benefit than shorter time periods. And future research needs to focus on overcoming barriers and facilitators to large-scale implementation. Certainly something for us to consider, because if we go back closer to our own backyard, this is the most recent publication I could find on early skin-to-skin contact in preterm infants. And here the question is not about clinical outcomes or improving clinical outcomes, but still asking, is it safe? And this is from our Italian colleagues. And if you look at the data, this is slightly more immature babies with an average median gestational age of 29 weeks. And here the median time to first kangaroo skin care was 10 days compared to 1.3 hours. Not quite the same population, but so distinctly different that it should make us think as to what we can improve, because I think we can agree that in terms of family integrated care, we have a long way to go to facilitate better integration, and that includes early provision of kangaroo care. But of course, it's not only about those simple investigations. We could also try to identify infants at highest risk. Simply measuring blood counts or inflammatory markers may not necessarily help, because it may not always give us the answer to the question that we're actually asking. And we should consider that all babies will be exposed to bacteremia intermittently. The question is, how well can they respond to it, and can they contain the infection? And what we've tried to emulate in laboratory investigations is that we took whole blood serially from babies born extremely early and did that during the first month of life. And then instead of just measuring soluble mediators, for example, or cell counts, we were interested in asking the question, how do these babies respond to the challenge? Can they adequately respond with inflammation and phagocytosis and contain the infection? Or can we identify babies that don't respond as well? And so what we did is we display the data here over the first month of life. These are cytokine responses in response to exposure in vitro to live staphylococcal epidermidis. And interestingly, we can see if we split the babies into the open symbols that denote babies that did not suffer from late onset sepsis versus those in the full circles that did suffer from sepsis, and the arrow indicating the time of onset of sepsis, we can detect differences even before the babies become unwell. So in the future, maybe we can identify babies at highest risk and provide some more detailed monitoring that highlights which babies could be at highest risk and may require further intervention. And with that, I'll conclude for today, and I'll be very happy to take some questions.
Thanks, Tobias. That was a really elegant overview of the infection, the process of infections, and what defenses we have available. But of course, you highlighted that there is a host response in the preterm infant. Actually, there's still quite a gaps in knowledge of how they do it specifically. Then you brought us to, going from that defense mechanisms, and can we treat that the early ones just didn't work, and then we came to the end of the barriers, which is the skin and the mucosa, where actually most of the information in the trials have shown a little bit of success, at least in reducing infections, which is really, really beautiful, I think. There's a couple of questions in the chat box. We'll start with, and they're all related to these kind of aspects, I think, of care and interventions. The first is related, I think, is a really important question from Amber. Mother's own milk versus PDHM. Does it matter?
That's a good question. I think the jury isn't entirely out on that one. It's probably somewhat better than formula, but clearly not as good as mother's own milk. For a variety of reasons. For safety, of course, donor human milk will have to be pasteurized, so you do have some loss, and we've demonstrated that in lab experiments as well. It's not as effective, but it is better than formula. And of course, it's also pooled. It's pooled from women shown to have more than the required supply for their own baby, so they can donate the surplus. So that will always be at a time that is later than might be ideal for the needs of the baby. If you recapitulate the graph that I showed, that the composition of the maternal breast milk changes over time, and babies receiving donor milk will always receive the mature milk that is lowest in the antimicrobially and immunologically active substances.
So, and related to that, I guess, we have started this PDHM. One of the reasons to get the plastic out, which is one of the messages you brought to us, getting plastic out is definitely beneficial and reduces your risk of infection. But what if the plastic is still in and you have an infection? One of the questions from Adi here is about, should you remove the line, or what is actually, is there advice about what you can do best?
Again, I think that is a decision that isn't so much based on trial data. There is no trial data on that. I think the infectious diseases specialists and microbiologists would agree with me if I said that ideally you'd take the line out. But clearly there are circumstances in a critically unwell baby where vascular access might be so difficult that you simply can't afford to take the line out. I would take the stand if you can, and if you can secure an alternative means of having vascular access, then it may help bacterial clearance if you did remove the catheter.
Yeah, I remember there was some descriptive trials from the Netherlands where they said all they did is remove the line and sort of the infection disappeared, which is, we find that difficult and we find that scary, I guess. I'm going to go do Prakash's question first, which is related to the lines. If you didn't have lines, and actually, I'm not sure if there were trials on this, vancomycin prophylaxis?
I only know of vancomycin used to sort of lock the line with, not of administering systemic vancomycin. I guess there could be a role for, you know, a dose or two of vancomycin if the central line was obtained under less than ideal circumstances. I think that could be considered, but again, there's little data around it. I think it's not practiced with a great deal of evidence anywhere to administer antibiotics purely for the presence of a central line.
There's a question here which is about proposed mechanisms. You talked a little bit about how some of these interventions could work or should work.
Yes.
Of course, it's surprising that the immunoglobulins didn't work, so that's sort of another way. But this question is about kangaroo care. How does that work? Or how do you think that works?
That's an excellent question, and I should have said that it could be a fantastic project to do kangaroo care and dive much deeper into the mechanisms. I think what's most commonly proposed is the change in the microbiome, that baby is much more likely to be colonized with the maternal mature kind of normal skin flora as opposed to the NICU environmental flora. That's certainly one important mechanism, albeit somewhat unproven and just hypothetical. But there are probably other changes to the immune system and immune functions that we underappreciate and simply haven't looked at. We know from the maternal perspective that having regular kangaroo skincare clearly is good for the production of breast milk, which in turn benefits the baby again. So I think there is a bit of an interplay between the two as well. But the short answer is that is an open field for beautiful studies to delineate what the key factors are. We don't really know.
Right. You sort of highlighted this, and often we have these bundles of care which reduces infection, and again, we don't know exactly which one did what, but it is the combination of all these aspects which works. And this is the same, I guess, how a standardized feeding regime could possibly work. And we had a little bit of chat before this session started about our fear of missing an infection, and I feel the same is happening in some centers, including my own, that, you know, introducing a standardized feeding regime is tricky. You get one NEC case and there is an association made between the two. So there is a reluctance to move forward. And we talked earlier about, you know, antibiotics in the more bigger babies with red lung, etc. So how can we do this? How can we change us, the neonatologists, the prescribers?
It will take time, I think. There is some evidence out there, but it always is sort of observational, anecdotal. It's not the highest quality evidence that we, you know, always wish for. But you know, some of my colleagues have really provided overview of a number of aspects around feeding and hesitance to feed babies, such as what is the actual relevance of gastric residuals, for example. You know, how important is the volume? How important is the shade of color? Is it actually normal to have a degree of gastric residuals in preterm babies? And how to move forward. Is it okay to progress feeds in the presence of whatever concurrent illness there might be? And so far, if you really investigate the available evidence, there is not much to say that we can't feed babies. More often than we think, we probably can feed them, and that's the success story, I guess. And if we look at data from clinical trials, even that investigated in infants considered at high risk with abnormal Doppler flows, for example, it seemed that the time to full feeds was much more governed by the physician's attitude toward the problem than the actual baby's behavior, indicating that, at least some of what we do or don't do is much more based in tradition, in culture, in fear than in evidence. So, yes, it was quite a journey, and I wasn't central to that work. That were other colleagues in our group that drove that forward. I think they would attest to the difficulty in achieving a pragmatic consensus. But it certainly has helped. So at least you have one central reference point that everybody in principle has agreed to, that doesn't say it is adhered to 100%, every single day, but it is something to return to, and, over time certainly contributes to changing culture.
Yeah. And an ongoing journey for everybody involved.
An ongoing journey
on any topic. Look, this question, Julie has been, hounding me on this question since we even started this sepsis thing. IVIC, I think she's convinced that IVIC, that should work, it must work, it should work. So is it really out?
I have little reason to believe that, at least as the Cochrane review concluded, for those previously tested preparations, there were a substantial number of babies of the appropriate birth weight we were most concerned about infection enrolled, and no benefit was shown, neither for prevention, nor, and you will recall the large INIS trial led from Australia, with over 5,000 or 6,000 babies, really substantial sample size that did not show benefit for the treatment of sepsis either. So personally, I don't think I would go there. There might be a role, in specific babies, but not typically preterm babies, but babies with, documented loss of immunoglobulins with a cardiothorax, for example, where it may provide some benefit. But for routine care in preterm babies, I don't see the evidence to support that.
Yeah, definitely not routine care, Tobias, but we've used it a couple of times in children and babies who are like backs against a wall, CMV infection. Don't know whether it was like serendipitous, coincidence, whatever, but it seemed to have a magical effect. And talking to the Red Cross here, they're very convinced it's very helpful, especially the adults with COVID. It's been a magical drug. Maybe, looking at a specific subpopulation, we might, consider like looking at IVIG again. Don't know.
Yeah, look, yeah. There could certainly be something in there, what you say, for a selected subgroup. As far as I'm aware, there were not many subgroup analyses done other than by gestational age, but certainly not by pathogen. And as you know, there is not always pathogen identification available for all the cases of late onset sepsis. So there are certainly some shortcomings in the evidence that we do have. Is it possible that for specific organisms in a specific context there might be benefit, or that is well possible, but not definitely not for prevention, I don't think, and not for general addition to every baby with late onset sepsis.
Definitely, yeah. Thank you.
Or I think we got time for one more question. There's a couple of questions which are related to the microbiome and how we can modulate it. For instance, with a cesarean section, can we do vaginal seeding in these infants? And I think I read different kind of strategies around it. So tell me what you think about that.
Look, I think it's certainly an interesting concept. I think it fits also with our concerns about perturbing the microbiome by administration of antibiotics, whether this is around cesarean section or after. I think that the jury is still out. The studies currently available aren't of sufficient size, but there was a new study that just came out this week in Cell, of all places. I forgot the number of babies included in it, but they did vaginal seeding following cesarean section and demonstrated distinctly normalized microbiome, and associated that also with better brain growth when they did MRIs in follow-up at 1 and 2 years of age, I think it was. So I think it's certainly gathering traction. I don't think it's ready for broad implementation at this point in time. I think we need to learn a lot still about safety and how best to do it. but I can see that potentially coming for babies in the future that are born by a cesarean section. I think that there are still remaining questions, about how to do this. Should we exclude mums that are GBS positive, for example? All these considerations, or mothers that are colonized with ESBL, which we increasingly are seeing. So I think, some very important points that need to be teased out, but in principle, it could be something.
Yeah. All right, that's the time for today. Thanks so much, Tobias, for speaking for us with this presentation. There's a couple of more questions in the box, but for the questionnaires, feel free to send them to Tobias. Again, thank you, and also thanks everybody for attending today. Next week, we continue actually a little bit on this topic, again, looking at the skin and skin breaks, presentation by Michelle Stubbs and Joe Davis from our nursing leaders, and it's going to be chaired by Karen Walker. So thanks, everybody, and I hope to see you all next week, same time.
Thank you. Bye-bye.
Thanks.